please. Thank you very much, distinguished Chairman, ladies and gentlemen. I will also talk about paravalvular leak after TAVI. And I would like to define the problem first. If you review the literature, you're going to see that paravalvular leak occurs in more than 60% of cases following TAVI, with moderate to severe defined paravalvular leaks reported between 9 and 21% after core valve implantation and 6 to 13.9 after Edwards sapien implantation. This is according to the review by General a few months ago in JACC. When we explore the partner trial, we see a very interesting finding that actually in the partner, patients with moderate to severe paravalvular leak actually had higher mortality at 1, 2, and up to 3 years. But even more interestingly, even patients with mild paravalvular leak had increased mortality versus patients with none or trace. In a multivariate analysis of the partner data, it indicated that even mild paravalvular leak has a hazard ratio of 1.47 and moderate to severe had a hazard ratio of 2.38 as an independent predictor of 1-year mortality. So there is an association in the partner trial between paravalvular leak and increased mortality. It doesn't define that this is the cause, but there is certainly an association. This is balloon expandable data. What about the core valve? What we have is the advanced, it's a large registry, it's not a randomized trial, but still in this registry, what you see here are the survival curves or survival event-free survival of patients with no or none or trace, mild, moderate to severe paravalvular leak. And in the advanced core valve data, you see that only patients with moderate to severe paravalvular leak had worse outcome or increased mortality. The p-value was borderline, but you can see that there was a numerical difference between the groups. This is a group of Marie-Claude Maurice and Thierry Lefebvre at Massy. They also published their data. You see the groups are distinguished between patients with AR grades post-TAVI 0 to 1, 2, or 3 to 4. Again, very similar phenomenon with increased mortality. The worst group with patients with severe, intermediate group with patients with grade 2, and the best group with patients with grade 0 to 1. And this phenomenon pertained when they sub-analyzes into patients with Edwards or core valves. And in the France 2, which is a very large French registry, in a multivariate analysis, they indicated that AR grade 2 plus was the strongest predictor for 1-year mortality with adjusted hazard ratio of 2.3. And I can quote many more articles, and this is again the general review publication, and most of the data would indicate using both univariate and also multivariate analysis, the paravalvular leak is associated with worse outcome post-TAVI, and there is also a meta-analysis of 45 studies, more than 12,000 patients with moderate to severe AR post-TAVI in almost 12% of the patients, core valve versus sapien 16 versus 9.1, moderate to severe AR increased mortality at 30 days, and one here with a hazard ratio of 2.3. And these are the forest plots for the moderate to severe. You see the hazard ratio here. And this is also for patients with mild paravalvular leak, which is again was shown in the partner trial, but not in the advanced registry. So you see here the hazard ratio was 1.83. Now, you know that TAVI is aimed to replace surgical AVR in patients who are poor candidates for surgery or no optional, patient with no option for surgery. So what we learned from the surgical literature, and this is a series of Tyron David, that up to 6-7 years, a significant paravalvular leak defined as 2+ or more than 2+ is actually quite rare in the surgical literature up to 7 years. And beyond that, you start to see degeneration of the valve. So this is not mainly paravalvular leak, this is mainly aortic regurgitation due to degeneration of the leaflet. So there is a benchmark here, at least for 7 years, that paravalvular leak should not, if we want to compare ourselves to surgery, paravalvular leak is a big no-no for surgery, and certainly, as shown by the TAVI data, it is a problem associated with TAVI as well. The next question is the sustainability or the durability of this phenomenon. So whether paravalvular leak change over time, and this is again the partner data you see here, that for example, if a patient had a mild residual paravalvular leak using the Edwards, okay, so most likely he would remain with paravalvular leak, but some patient would have, during follow-up, better finding, which means trace or none, but few patients would deteriorate over moderate. And so the finding most likely would be preserved. Some patients would improve, few patients would deteriorate. Very similar picture we see in the advanced registry. You see here the breakdown between mild, moderate to severe. So immediately post or at discharge, 15% of the advanced using the core valve had moderate to severe, and over time, 1 month, 6 months, and 12 months, 1 year, it decreased to between 10 and 12%. So this is a durable phenomenon. We cannot say that the patient that had paravalvular leak, which is more than trivial or moderate to severe, certainly after the procedure, most likely it would disappear, and this is not the case. One of the reasons why this is not a healthy phenomenon, quote unquote, is this very problematic trade-off between pressure overload and volume overload. This is due to the fact that the non-compliant hypertrophic left ventricle, which has been adapted to chronic pressure overload, is unable to increase the end-diastolic volume, so that the LVEDP increases rapidly with consecutive decrease in cardiac output, leading to hemodynamic deterioration. Again, this is a mechanism. We don't really know whether this is really the cause of death in this patient. Why is that? Okay, so we define the problem. We see it is associated with a worse outcome. We know it's most likely sustainable. Now let's talk about the mechanism of paravalvular leak post-TAVI, the anatomy, the pathology, and the impact of the devices. And we can distinguish between factors that are related to the native valve and factors that are related to the device. In terms of valve, we know that the aortic annulus is an oval-shaped. Mostly we have problem with large annulus, surface irregularity due to extreme and eccentric calcification, and also we have the problem of bicuspid valve. In terms of the device, we have the problem of incomplete apposition of the device within the annulus, measurements leading to under or oversizing, and device malposition, too high or too low implantation. So let's elaborate on that. This is on the left panel, you have a very pathologic valve, native valve with tri-leaflet and severe aortic stenosis, and on the right panel you have the normal valve. Now just imagine what is needed here to implant a circular shaped device, which is the stent that covers the valve. So you see the surface irregularity, you see that it's not circular. So are you going to implant a stent that is going to look like that and look at the gaps created, or even something which is more larger than that, but still you're going to have some gaps, but you start to risk the patient with another problem, which is an annular rupture, a very complex problem to solve. This is another imaging modality. On the right panel you see here the 3D TE. On the left you see the CT, and again you can appreciate that the annulus here is not round, it's oval, and the stent on the scaffold that they are going to place that encircle the valve is actually round. So how it would adapt to this annulus, again, it is a problem, and you can appreciate that the potential for gaps between the valve and the annulus is a very real one, as depicted in this slide, when you see actually gaps between the sapien valve and the annulus in an ex vivo model. Now, in terms of the core valve, what are the mechanisms of paravalvular leaks? There are four main mechanisms. One is the heavy calcified caps that cause the gaps with the calcified nodules. The problem of malapposition, whether the valve is too high or too low. Too high is too shallow towards the aorta, too low is towards the LVOT, with gaps created above the skirt. And also undersizing when the valve is too small, not fully expanded, or there is a very elliptical annulus. Same problem could occur with the sapien. There are several mechanisms of paravalvular leak. First of all, which is extremely rare, it's intravalvular regurgitation with dysfunctional leaflets, as you see here. The other problem could be gaps due to irregular surface or calcium nodules, the valve undersized or not fully expanded. The next problem is implantation too deep into the LVOT with aortic regurgitation above the skirt. And the final one is implantation is too shallow or too high towards the aortic root and the aortic regurgitation below the skirt. It is not a trivial technical matter to stick the valve exactly to the annulus, to seal it completely, and to have no paravalvular leak. Those of us who are doing the procedure knows that it's not trivial. It's a matter sometimes of few millimeter up or down, or few millimeter in terms of election of the size of the device in order to end the procedure with moderate, mild to moderate, or no leak at all. And the question is how to avoid paravalvular leak towards TAVI. And I think the key message here is procedural planning with very careful measurements of the annulus and try to best match the device to the annulus. And there is a paradigm shift over the last 2-3 years from initial TAVI cases that are mainly based on echo and TE measurements to MSCT, which is now considered as a gold standard. And there are very detailed and methodology that was developed to measure the diameters at the long and the minor axis, the perimeter, the cross-sectional area, and there are these tables that are very, very important both for core valve and for Edwards sapien in order to best match the device for the perimeter to the cross-sectional area. Actually, in the core valve, for example, we tend nowadays to oversize both MSCT perimeter by between 15 and 20%, with a very careful attention to the height of implantation. We are very fanatic about where we are going to place a valve. We aim at higher implantation as possible, but obviously not too high that the valve would not jump into the aorta. And we also want to identify the optimal landing zone so that the valve would not be implanted too high or too low in order to avoid these deleterious leaks. Same problem, but not identical as regard to the sapien valve. We are talking here about oversizing, but less than with core valve. We are talking between 5 and 10% of oversizing at most in order to avoid the other problem, which is the annular rupture, based on MSCT, cross-sectional area, perimeter, and echo. Adjustment with balloon filling, we can underfill with the balloon by 1-2 cc when needed. Overfilling is possible, but would not do much. And very careful inspection for eccentric calcium nodule in order to avoid this problem or this hazard of annular rupture, which is rare, but when it occurs, it's a real catastrophe. And there is at least one publication which talks about the cover index, which is the prosthesis diameter minus the annular diameter divided by the prosthesis diameter, again as a measure of the optimal matching between the device and the annulus, and also identification of the landing zone where exactly we want to place the valve in order to avoid, as I mentioned, too shallow or too deep implantation. There is also this online intraprocedural method that was we taught by Alain Cribier, which is a root injection during balloon aortic valvuloplasty in order to delineate the potential leak, to match the balloon sizing to the annular sizing, and also to look very carefully what we expected to happen to the coronary artery. Now, the next question is how to assess the severity of paravalvular leak. And really, when we talk about the assessment, it's very critical because the assessment would dictate whether we need to do something with paravalvular leak ad hoc, whether we need to implant another valve, whether we need to do a post-dilatation. And the assessment is really multimodality. One, we're talking about angio-injection, we're talking about exploration of the echo, and a very detailed assessment of hemodynamics. First of all, we have the root injection with the Seller's criteria of AR. Seller was the pediatric cardiology who worked, I think, at the Cleveland Clinic, and he developed this methodology of mild AI, moderate, and severe AI based on the retrograde inflow of the contrast from the aortic root into the LV. The hemodynamics never lies. According to many labs experienced, if you see this phenomenon of very low systemic diastolic pressure, high rise of the LVEDP, and very small gap between the systemic and the LVEDP, so this would indicate that most probably we are talking about significant aortic regurgitation, which is usually also rate dependent, and this is a sign that something needs to be done. And there is also this index which is called by Sinning in his publication 2 years ago, the AR index, which is defined as the diastolic blood pressure minus the LVEDP divided by diastolic pressure times 100, and when the AR index is less than 25 or more than 25, for AR index that are excessive, the mortality at 1 year are much higher compared to patients with increased AR index. So AR index is another sign. The VAC2 has very clear definitions, which are nowadays based mostly on echo. In very practical terms, and we use it in the lab, we look at the arc of calcification by echo in the short axis. There are some additional measurements which are very, very important, but if the arc of calcification is less than 10%, we define it as mild. 10 to 30% is moderate, and more than 30% is defined as severe. These are two examples. This is an implantation of sapien valve at our lab, and you see here a patient with residual mild but solid mild aortic insufficiency, and this is a patient with a core valve with residual moderate plus, I would say, aortic insufficiency, and obviously I can show you more example of that. The next question is how to treat a significant paravalvular leak. So one issue that needs to be remembered, there is an option to post-dilate the valve, but not in every case. In a very selected case, as depicted in this size with sapien, and in this size with core valve. And this is mainly in cases where there is under-expansion of the valve or gaps created between the device and the annulars. This is for both valves, but one should appreciate the potential hazards associated with post-dilatation, which are valve migration. It should be done with very careful pacing. Stroke, there are some data to indicate that there are increased stroke rates in post-dilatation, and annular rupture could occur and coronary obstruction. Post-dilatation is an option in carefully selected patients, but again, it is not a trivial procedure. When the valve is really too shallow or too high, this is the time to implant another valve and not to hesitate, not to blink about that. This is a patient from our lab when we implanted the sapien valve and the implantation was too deep into the LVOT. There was excessive paravalvular leak, and we immediately corrected this problem with the implantation of another sapien, and actually we created one consecutive valve and we got a very good result. And this is another very opposite example from our lab when we implanted the core valve, which actually dived into the LVOT. We got excessive paravalvular leak above the skirt, and again we corrected this by the implantation of another valve which was around 10 to 12 millimeter above the original valve, and we ended up without any leak at all. Very, very good result. There is the snaring technique that can be performed. We can use the different poles of the device in order to snare. We can even use 2 snares. It is helpful to some extent, but according to my experience, it is not very, very helpful when there is a severe leak. So one can start with snare, but if it's not helpful, then probably the next stage would be to implant another valve. I designed here a final algorithm how I think the paravalvular leak problem should be approached. First of all, if you are doing TAVI, you have to define the AR severity using the angio, the hemo, the echo, and you have to ask yourself a question whether it's moderate to severe. If the answer is no, you can accept the final result, observe and follow. If the answer is yes, you have to define the mechanism. If the mechanism is annular prosthesis size mismatch, large calcium or gaps, probably the solution could be derived from balloon post-dilatation. If the valve is too high or too deep, consider snaring, or probably you should consider a second valve implantation. And I can tell you that most of what is defined as next generation devices are aimed not only to improve TAVI result, but also to decrease this problem of paravalvular leak. So you see here all kind of emerging solutions to deal with this problem with scarf and skirt and everything that needs to seal better the interaction between the valve and the native aortic annulus. So in conclusion, ladies and gentlemen, significant paravalvular leak occurs following TAVI in up to 20% of cases, and it is associated with worse clinical outcome, as I showed. Procedural planning using the TE or MCT guidance for proper sizing should reduce paravalvular leaks post-TAVI. Proper valve placement is mandatory to avoid device malposition that may cause significant paravalvular leak in AR. Severity of paravalvular leak post-TAVI demands precise assessment using angio, hemodynamics, echo, and clinical expertise. And ad hoc management of moderate to severe paravalvular leak is mandatory, including post-dilatation, valve snaring, second valve implantation when appropriate, and in the future, external wraps around the valves and advanced imaging guidance should eliminate this problem. So I think that I hope that I was able to convince you this is something to be avoided, and we would like to avoid this scenario when we are doing the TAVI and we come to the patient who had stenosis, and now you tell him, you know, we eliminate the stenosis, but you have a leaky valve. So the patient would say, wow, I don't understand why it was stenosis, why it leaks. We don't know, we don't want this phenomenon. Thank you very much.
Ran, I have one short question. We all know that the mechanism you showed here so nicely, but the only problem that still exists while we are improving our technical and devices and everything by putting it in place and by measuring it accurately, but one big enemy remains there, and this is the calcium. This is the bad guy of the TAVI. Now, do you think there is anything in the future like the toy that Moshe Fligelman is planning for us with the laser breakage of the calcium? Do you think there is any future directions in this kind of solution?
First of all, I think that I have no doubt this problem would be eliminated. I'm very optimistic. The most exciting thing I've seen is, for example, the Sapien 3. Very exciting. and I think very smart as well. And some other, future generation devices that I think would eliminate this problem. The question whether you need to perform another procedure such as pi-r square relief that you've mentioned to eliminate the calcium and then to implant the TAVI is also very provocative, very intriguing, but remains to be seen. Maybe, but I think that the solution would be derived from better designs of the valve with a careful attention to what's going on not just inside the scaffold but also outside the scaffold as the direction that the Sapien 3 I see is going towards.
Thank you.
Thank you very much.